Good afternoon. Oh, what's that? Sorry, guys, hold on. What's gonna happen? Good afternoon, everyone. I am Melissa Bustamante with the Illinois chapter, American Academy of Pediatrics, and I thank you for joining us for today's webinar on business side of vaccine. Today, we are joined by Becky Dolan from the American Academy of Pediatrics. Before we begin, I would like to go over a few housekeeping items. The webinar planning group was by these individuals, and they were CME application reviewers. Nobody on the planning group, presenter, content reviewers, and CME applicant reviewers had any disclosures, as well as the CME accreditation is through the Illinois State Medical Society. All right, so participants' phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel for the webinar on the right-hand side of your screen, and Ms. Dolan will answer them at the end of the presentation. Ms. Dolan holds a master's degree in public health education from Tulane University. She has spent the past 8 years at the American Academy of Pediatrics working in the Department of Practice on coding, private payer, and Medicaid issues. She is a certified professional coder and a certified pediatric coder through the American Academy of Professional Coders. Prior to starting her work with the AAP, she spent over 15 years working in a private pediatric office where she worked in the front office coding and billing and also part of the clinical staff. Please join me in welcoming Ms. Dolan.
Hi, good afternoon, everyone. Sorry for that pause. I'm hoping that everything transitioned over well. Me and technology don't get along always. I believe I unmuted myself, so hopefully you're all hearing me. So again, welcome to today's webinar. I feel like I've been doing this webinar for quite a few years now, but they claim they keep getting people back, so I'm happy to be here every year to go over the coding. As Melissa mentioned, there's no disclosures. I have nothing to disclose for today. This slide is just going to go over some objectives. I don't want to go through this completely, but just, the point of today is to really help you to better understand vaccine coding and some of the crazy nuances we have in coding. Some updates for this coming year, both clinical recommendation updates as well as some coding updates. And I hope you also enjoyed this webinar. So first, we're going to start off with what we all know and love, and that's our pediatric immunization administration codes. These have been around, I feel like, for quite a long time, but they still cause a lot of confusion and questions. So I still want to go through all of this. I do apologize for all of you who've been doing this for years and are looking more for the updates, but I still think even the seasoned veterans get confused, as sometimes I do as well. So I have to stop and think these through. But our pediatric specific immunization administration codes are codes 90460 and 90461. Keeping in mind, these codes may only be reported for patients who are under 19, so they're through their 18th year of age, any route of administration, with counseling by a physician or other qualified healthcare professional. The unique thing about these codes is that they're component-based. The first code, 90460, is reported for the first or only component of the vaccine, while 90461 is added on to 90460 for those vaccines that contain multiple components. You will only report 90461 in addition to 90460. We still continue to get questions about what is an other qualified healthcare professional. CPT made this distinction. We often get questions, why did the AAP change this? And this had nothing to do with the Academy. This was all related to the American Medical Association CPT book. They decided to define what an other qualified healthcare professional is. And you can see it here, but the gist is someone who can independently report a professional service, meaning they don't work under someone, such as a physician or nurse practitioner. So they are distinguished from who we call clinical staff. And those are the people who have licenses within states but do not independently report services. We typically define those as registered nurses or licensed clinical nurses. So the other aspect of our pediatric vaccine administration codes are components. What is a component? And a component does refer to each antigen in a vaccine that prevents diseases caused by one organism. Conjugates or adjuvants contained in vaccines are not component parts. Therefore, multivalent antigens or multiple serotypes of antigens against a single organism are considered a single component of vaccines. So let's translate that over. HPV, single component vaccine. Influenza, be it a trivalent, quadrivalent, doesn't matter, single component, single disease. Meningococcal, pneumococcal has several valents in them, still a single component. Now, traditionally speaking, I don't think many of us considered a DTP or MMR to be a multiple component vaccine, but it is. So the DTaP or Tdap is indeed a 3-component vaccine. So that translates into reporting 90460 in 1 unit and 90461 for 2 units for the additional components. You can see the rest listed here, but this basically translates over what the previous slide just said in a lot of crazy words. So now we have to figure out, does the patient qualify for our pediatric vaccine code? So first, let's start off with, is the patient 18 years of age or younger? If it's yes, let's go to the next step. Is there a documented physician or other qualified healthcare professional counseling? If the answer is yes, we can now report our 90460 and 90461 codes as appropriate. If anywhere along the line the answer is no, we have to defer to our other set of vaccine codes, which are CPT codes 90471 through 90474. We'll talk more about those. So again, if we don't have both criteria met, both criteria, so 1 and 2 have to be met, then we're going to report what we refer to the non-age specific immunization administration codes. So these are the codes you're probably more familiar with if you've been coding general pediatric care for a long time. So 90471, 90472, 90473, and 90474. These are the codes that must be deferred to if indeed you do not meet the 2 requirements. Patient is under 19 or 18 years and younger, and there's qualified healthcare professional or physician counseling for that vaccine. So let's say we find ourselves in that position. We now have to defer to these codes. These codes are very different from the previous ones mentioned. 90471 is used for the administration of a single or 1 vaccine, whether it's intradermal, subcutaneous, IM, doesn't matter, all injections. If you give additional injections on the day of service, we need 90472 listed in addition to 90471. However, let's say we're giving a FluMist. Only vaccine given that day, we're going to have to look at these set of codes, 90473 through 90474. 90473 is a single vaccine or 1 vaccine by oral or intranasal route. You will report 90472, which is our additional injection, in addition to a 90471 or 90473. You will report 90474, which is the additional intranasal or oral, in addition to 90471 or 90473. You can never report 2 first vaccine codes. You cannot report a 90471 with a 90473. So in looking at the 2 vaccine codes side by side, here are the distinctions. So again, requires physician or other qualified healthcare professional counseling. That's only under our 90460. Reported based on route of administration is only 90471 through 74. We had the two sets of codes, the 9047172 for injections, 9047374 for oral or intranasal. Remember your 90460 code, it does not matter route of administration. We do not care. The only ones reported per component is the 9046061. You cannot count additional components if you're using your 71 through 74 codes. The only ones that have a specific age requirement is 90460 through 90461. Those patients have to be under 19 years of age. We get asked a lot about what is required for documentation for counseling. The physician or other qualified healthcare professional must document that all vaccine components were counseled on. Documentation should reflect what was done, just like any other CPT service. It's important to note that the guardian and patient has received the VIS, the vaccine information sheet, any risks, benefits of the vaccines that were discussed, issues or concerns addressed by the parents. Mom and dad have any questions? And the care plan over the next few days to deal with possible side effects. And again, this is guidance. This is not written in the CPT manual, but this is the things that an auditor might look for when you're reporting your vaccine administration codes with counseling. So continuing on with this counseling aspect, let's say a patient presents for vaccines and your physician or qualified healthcare professional does not counsel on all vaccines. They might be getting a second in a series and then they're getting their first flu shot. So the physician may not counsel on one, but counsels on another. You will only report the 9046061 for those that have actually been counseled on and there's documentation to support. So let's say, for example, your physician counsels a mom on the MMR, but not the annual influenza. You will report the 90460 and 90461 with 2 units for the MMR. However, because there's no counseling for the flu, you will report the 90472 if this was an injectable influenza. You cannot report 90471 with 90460, hence why we're using the additional vaccine, the 90472 code. If it had been the intranasal, we would be reporting the 90474 for the vaccine. Another question we get asked a lot, and this is actually, there's a lot of rumblings coming up through a lot of vaccine support groups about this, and some vaccine advocacy groups about this whole counseling for immunization administration. As it stands right now, if you counsel for vaccines on a different day than you administer them, you don't get credit for that counseling when the vaccines are given, meaning you cannot report the 90460 if counseling does not occur on that date the vaccines are actually administered. So we talked a little bit about when to report your vaccine administration codes. We often get asked a lot of questions and a lot of claim denials come back when we realize that vaccine administration codes are being inappropriately reported. So we're going to quickly go through that. An area where vaccine administration codes should not be used are for immune globulins. Those run through the range of 90281 through 90399. These do identify the immune globulin product only, but these are not vaccines. So you will defer to the 96372 administration code. So a very popular one here in pediatrics is the RSV. We give that to all our preemie babies that require it. The product code is the 90378, but the administration code is the 96372. This is not a vaccine or toxoid. Do not report vaccine administration codes. The next we get asked a lot about, and this is the PPD test. This is reported currently with 86580. Again, this is not a vaccine or a toxoid. You cannot report a separate administration code, whether it be the vaccine admin code or the 96372. The 86580 does take into account administration. So switching gears now, we've talked again about the administration side, but every administration has a product that goes along with it. So over the next several slides, we're going to go through our vaccine products. So these are found in the medicine section of the CPT manual, which for those of you new to coding or not familiar, that's the last set of codes in the CPT book. They run the range from 90476 through 90749. These codes identify the vaccine product only. You will use these codes in addition to the appropriate vaccine administration. So common codes in pediatrics you'll see are the 90700, the 90723 for the Pediarix, 90716 varicella, Hep B, 90744. And it's important to remember that if a combination code exists for the vaccine, such as the Pediarix, you will not be reporting the individual vaccine codes, meaning you would not report the 90700 in addition to the 90744, in addition to the IPV, if you give a Pediarix vaccine. You report the combination code. So in this case, 90723. Vaccine product codes are updated just like every other CPT code. It's very important to stay on top of that because unlike most CPT codes, they are updated twice a year. You can expect to see updates in January and July. Codes posted on January 1st become effective the following July 1st, and codes posted on July 1st will become effective the next January 1st. Vaccine product codes are often released before the vaccine is even on the market or before it has FDA approval. If you see a vaccine with a lightning bolt next to it that indicates the vaccine is pending FDA approval, you should not report that vaccine unless you have specific permission to do so from your payer. They will most likely deny. I've listed the website here for the site you can go to. You can bookmark it, and this will always provide you with AMA updates to vaccine codes throughout the year. So when reporting our vaccine codes, again, we talked a little bit about this before. It's important to look at all aspects of the product before you choose a code. So again, when looking at the product, is it a combination versus single component? What disease is being targeted, such as hepatitis B? Is there a change in dosing schedule? Hib vaccines have 3 and 4 dose schedules. Age indicators, if there's age indicators listed. Chemical formulations, is it a polysaccharide, a conjugate? Routes of administration, is this a subcutaneous vaccine or is it the intramuscular? And important for our influenza codes, is it preservative or no preservative? So there are a lot of things to take into account to ensure that you are reporting the most appropriate vaccine product code, because a result of it could either have a denial or an underpayment or an overpayment you end up having to pay back. We've already talked about this, so I don't want to go into this anymore. But again, remember when you're reporting a combination vaccine versus single elements of the vaccine, you do want to make sure you're reporting the combination code if you're giving a combination vaccine versus the individual products. Now let's look at our vaccine product updates for 2019-2020. There are not too many updates this year. It's been a little bit of a quiet year, so it's kind of nice. Again, always be sure to understand your CPT symbols. That lightning bolt's very important. That means that the FDA is still has not approved the vaccine. The dot's a new code, triangle will result in a revised code, and then we're seeing these hashtag pound signs everywhere, including CPT. They're not making a statement, it just lets you know that the code is resequenced, which you're seeing a lot more now in the nomenclature. All right, so we have a new code. Again, still FDA approved. It was released July 1st. These two codes were updated on the website we spoke about earlier on July 1st, and they will be published in CPT 2020. So we have a new code for the meningococcal conjugate vaccine for these specific serogroups. It's a tetanus toxoid carrier for intramuscular use. As of right now, I don't believe there is a vaccine on the market, but obviously if they got a new code, you should be on the lookout for one. And that resulted in a revision to one of the meningococcal conjugate vaccines. So just be very careful when this does come out on the market that you are using the appropriate code. The tetanus toxoid carrier, which is the new code 90619, versus the diphtheria toxoid carrier, which is the meningococcal conjugate vaccine, Serorups ACWY, quadrivalent diphtheria toxoid carrier, or CRM 197 carrier. That is what the 90734 will look like in your January 2020 CPT manual. We also have a new code for an influenza vaccine, 90694. Again, I don't believe this is on the market yet, still FDA pending, but be aware that this could come on the market and you'll have a code for it. This was released again on the January 1st update on the website. The effective date is January 1, and again, you will see this in CPT 2020. So that segues us into our favorite time of the year, which is influenza season. Influenza vaccine products are starting to shift more and more to the quadrivalent side. We're seeing very few trivalent vaccines, which on the coding side is lovely because it's less codes to confuse. But still, when we are choosing the vaccine product to code for, there's a lot of things to keep in mind on that front. So ask yourself, what was the route of administration? Was it an intradermal? Was it IM? Was it intranasal? Again, preservative or no preservative? Was it antibiotic free? What was the dosage given? They're messing with dosages this year. Was it a 0.5 or a 0.25? And again, tri versus quad, although we're seeing a lot less trivalent vaccines on the market. This chart is for your reference only. We try to do, they really do a number on these vaccines every year, so we try to keep a really close tab on them as best as we can to ensure that we're giving you guys the appropriate code for the vaccine that's given. We're providing you with some age recommendations. So again, this is just for your reference. So now we've chosen our code, we're coding right. How can we ensure to some degree that the product will be covered? So we've talked a lot throughout this about FDA approval. Without FDA approval and the Center for Disease Control's Advisory Committee for Immunization Practices, or ACIP, or the AAP/AAFP routine recommendations, a vaccine will not be covered by most, if not all, payers. Payers write their policies based on routine recommendations. There are always exceptions, but you always want to double check those first before providing vaccines. I've provided a couple of links on this page, and this is the CDC ACIP website. It's important to have. I would definitely bookmark it if you're coding or you have questions or concerns about routine recommendations, as well as the AAP's Red Book, which offers very similar recommendations, but that does require an AAP login. So again, we talked a little bit about payer coverage. It's going to focus on things like ACIP recommendations, which is the CDC arm. Publications of recommendations in the MMWR, that is the publication from the CDC called the Morbidity and Mortality Weekly Report. Once the recommendations are published in there, payers have access to that. It is very important to just never simply follow what the manufacturer recommends. Sometimes that will vary from the routine recommendations. Just because a vaccine is safe for a 2-year-old doesn't mean it's recommended for a 2-year-old. You want to be very clear when you contact a payer to get something in writing that the vaccine will be covered if it's outside of ACIP recommendations. And I know that's important for travel purposes. A lot of times when there's travel, that will go outside of routine recommendations. Now remember, there is some lag time between FDA approval and released recommendations. So a vaccine might be approved under FDA, that lightning bolt might go away, but ACIP has not released their recommendations. So always be careful with that. You know, vaccine manufacturers like to get the word out and let them know they have a great new product, they're excited. But before you start automatically giving these vaccines, ensure that there are routine recommendations that will be covered by the payers. This is just an excerpt I took. Obviously, please don't read this, but it's just to let you know what it'll look like within one of these reports under the ACIP website. When you click on a hepatitis vaccine or influenza, you want to look for the word recommendations. And this will highlight and outline exactly what the routine recommendations are. And this, again, is what most payers are going to follow. So you want to keep close tabs on these recommendations. So in a nutshell, the vaccine is FDA approved. You are giving it within ACIP AAP recommendations. Are you giving it in the compliance with the FDA and AAP and ACIP recommendations? If the answer is yes, you will have this vaccine covered. And again, this is non-grandfathered plans. There are always variations for some of our grandfathered plans. Those are starting to go away a little bit, but you can pretty much be guaranteed if you're following the FDA approval, you're following the recommendations, you're giving it within those recommendations, yes, that vaccine will be a covered vaccine under the payer. So just some heads up, you might all be aware of this, but it's always important to know when ACIP does update recommendations, you will see on that website I listed previous, there'll be a new note next to it letting you know that there's been an update to the recommendations or some sort of change has been made. So for this year, they did have 2 updates. They did change this one in October of 2018, but apparently a lot of people were not picking up on it. So they wanted to get the word out that the Afluria quadrivalent is now licensed for persons aged 6 months and over. That is a change from before. And it's also now licensed for children aged 6 through 35 months at the 0.5 ml dose. Previously, they were given the 0.25, but apparently those recommendations have changed. And they are allowing that to happen. So again, we kind of talked about earlier, don't just look at ages, you got to look at the dosage because some of these dosages are now 0.5. So if you think the patient's 10 months old, they get their flu vaccine and you automatically think they're going to get the 0.25, you're going to be reporting the wrong code. Same with the Fluzone. In January 2019, the FDA did approve a change in the dose volume for the Fluzone quadrivalent. Previously, the dose volume for children aged 6 to 35 months was 0.25. Children aged 6 through 35 months who receive the quadrivalent now may receive either the 0.25 or the 0.5, which I find a little confusing, but that's what it says. The recommendations say that as well as the package insert. So just pay attention and keep in mind all these changes that are coming around because this could impact the coding that you're doing. If you're so used to seeing a 10-month-old getting a 0.25 and you code for that, but they got the 0.5, there's going to be a problem. So just keep aware of that. The Academy does keep a vaccine coding table. We do update it as often as we can, and we do try to stay on top of changes with the recommendations and vaccines and new vaccines on the market, vaccines taken off the market. This is a link to that site. Again, if you want to download it or keep it somewhere so you can always have the most updated information. All right, so we've now coded right, we've got the right vaccine, we have our administration codes, we know it's covered. Now I want to talk a little bit about the payment side. The American Academy of Pediatrics has an arm that talks a lot about private payer advocacy and child health care financing. And they do a really good job of trying to analyze costs and payment and where we should be at. So they've done a really great job putting some information together. So all of this comes from them. I am plagiarizing them, but I work with them, so it's okay. So when you're paid for a vaccine, it should take into account several things. If you pay a certain amount for a vaccine, it's not an exchange rate. You shouldn't just get that amount back. You definitely shouldn't be getting under that amount. But in addition to what you paid for it, you should be looking at things such as personnel costs for ordering and inventory, storage costs. You're storing these vaccines. You have to keep them cool at the right temperature. Recovery of costs attributable to inventory shrinkage, wastage, and non-payment. This could happen if a patient refuses a vaccine after it's been drawn up. And then lost opportunity costs. So this is the cost associated with maintaining a large vaccine inventory and it's just sitting there. You've already spent this large amount of money. You have a lot of vaccines sitting there and they're just sitting there. You're not making the money on them. In addition, payments for vaccine products must be free of any discounts and based on a transparent and verifiable data source, such as the CDC vaccine price list for the private sector. And I will include that link. It should cover the vaccine product purchase price as well as all related office expenses as noted in the last slide, and a return on investment for the dollars invested in the vaccine inventory. We do recommend that it be at least 125% of the current CDC vaccine price list for the private sector. Again, that's a website that's maintained by the CDC, and we do have the link in this webinar. So what happens if you find that your payment rates are below this? Well, be sure to look at your contracts. We get people who contact the hotline at the Academy all the time about vaccine payment, and we always tell them, you know, vaccine pricing is based specifically on your contract, so we always need to know where the contract is. If unfortunately your contract was written 7-8 years ago and it's based off of those rates back 7-8 years ago, there's not much we can do until we can get your contract renewed. So we always tell and defer everyone back to your contract with the individual payer to kind of see where we're at. So make sure they're paying what was negotiated in your contract. If you should be getting a certain price and should be higher and you're not getting it, we need to find out why. But again, if they are paying at a lower rate because of what your contract says, we need to look at ways to renegotiate that contract and get the more current information that they're paying at the current fiscal year price instead of a previous year price. Remind the payer that these indirect costs that we spoke about previous in these slides, all the inventory, the shrinkage, the personnel costs, they're not taken into account with the vaccine administration codes. We know specifically what goes into those codes, and none of that we spoke earlier on are included in the payment for vaccine administration. So what happens when a vaccine is not given? So you do your job, you're diligent, you talk to the family, you say, little Johnny is due for these certain vaccines. And the vaccines are not given that day. So we do have a whole slew of ICD-10 CM codes that do allow the physician to report vaccines not being administered, and the reason why. These are reported as secondary codes to your well visit or maybe something else that has happened at that encounter. However, the one drawback is that they're not specific to show which vaccine was not given. So we know that a vaccine was not given. It may have been all of them. Or may have just been one, but we have no real good way of showing that right now. This is just a running list of all the vaccines. So you have the ICD-10 codes for vaccines not given. A caregiver may refuse. The patient may already have had a disease. We do have a newer one for unavailability of vaccines, and that's if there's a shortage. You may be able to show that vaccine was unavailable at the time, which means the patient may want it. So that's a good way to track patients when you have to recall them when the vaccine is available. So let's take a look at a quick example here. So a 12-month-old patient presents for a well check and vaccines. Patient contracted the chickenpox at 10 months of age. Patient receives the Hep A and MMR, but at this time did not receive the varicella. So you're going to report your 99392, which is your preventive medicine service for the patient based on their age. You're going to link it to the Z00.129 ICD code to show that it was a routine well check and there were no abnormal findings. You're going to list the Z23 to note that there was an encounter for immunizations. And you're also going to list the Z28.81 vaccinations not carried out because patient already had disease. So in addition, you're going to report the code for your MMR, your Hep A, then your appropriate vaccine administration codes, and you'll link all of those to your Z23 code. And that's the encounter for immunization. Let's look at another example. So a 13-month-old presents for routine well child exam. The parent is informed that the child will need her MMR and varicella. The mom refuses, stating she believes both vaccines are harmful and would like her child to be older. Despite counseling the mom about the vaccines, she still refuses. So you're going to only report your 99392. You're going to link it to your routine well child exam, your encounter for immunizations, and your Z28.82. Vaccination not carried out because of caregiver refusal. Unfortunately, you cannot report counseling in this case because it is considered part of the routine preventive medicine service counseling you do for that day. So again, as I mentioned earlier, there's no way to note that a particular vaccine is not given. So in this case, and this is a concern because they're looking at the HPV rate. So there's no way to really show that it was the HPV that wasn't given because of caregiver refusal or patient refusal or whatever the case might be. So in addition, you have an instance, and we hear this a lot, vaccines are drawn up, but they're not given. A patient is told or they need a vaccine, the parent agrees. After vaccines are drawn up, the parent or patient then decides they do not want them and refuses it. What are your options? Are you just simply out the money? It's important to prepare for these situations in advance. Once they've happened, it's kind of difficult to backtrack. Always look at your payer contracts for options on these sorts of situations. You may want to contact some legal counsel about drafting an office policy that makes the parent or patient responsible for any costs, and also learn some coding options you may have. But again, keep in mind that the Academy does fight for vaccine product payment above and beyond costs to account for some of these waste opportunities. In addition, some payers will allow for payment when the product code is submitted with the JW modifier. This is where you want to check some of your contracts first before you're submitting. In addition to all of the vaccine refusal codes, we do have another ICD-10 code that's important in these cases where a patient does not receive their appropriate vaccines. And that code is Z28.3. This is for under immunization status, delinquent immunization status, or a lapse in their immunization schedule. Use this code as appropriate because, again, it may help you internally track patients as well that need to be brought back for vaccines. Let's look at immunization administration and E&M services. So E&M stands for evaluation and management. In our case, we're going to be talking about office-based E&M services. So if a significant, separately identifiable E&M service is performed, the appropriate E&M service code should be reported in addition to the vaccine toxoid administration code. Modifier 25 will be required when reporting a problem-oriented E&M service in addition to immunization administration. So if you're reporting a 99213, append modifier 25. In addition, most payers are requiring the modifier 25 on preventive medicine services. So if you're reporting a 99391 and you're giving vaccines, append modifier 25. But remember what modifier 25 stands for. It is a significant and separately identifiable E&M service by the same physician on the same day as a procedure or other service. The service being modified should be above and beyond the other service provided and substantiated or supported by documentation that satisfies the relevant criteria for the respective E&M service. Most importantly, though, it should be medically indicated and necessary. We're asked this a lot when it comes to vaccine-only encounters. So if a patient is presenting for the sole purpose of a vaccine, which is extremely common in flu season, Common when a patient may need a second or third HPV, they already had the routine well exam and patient is fine, there's no concerns. So if the vaccine is the only thing that is addressed and nothing else is brought up, you will code only for your appropriate vaccine administration and the vaccine product. You would not report a separate E&M service in this case unless the service does meet the criteria. Was something else addressed? Did something else need to be addressed at that time? Did the patient possibly have a reaction to the last vaccine that they may need to discuss with the physician? That's different. But if they're simply coming in for vaccine only, report the administration and product code only. So what about 99211? What is our 99211? Well, that is our lowest level established patient E&M code. It is commonly referred to as a nurse visit. The reason it's called that, it doesn't require key elements, and it doesn't require the face-to-face encounter with a physician. When a patient sees the nurse for immunizations only, you will not report a 99211 in addition to the product and administration code. However, you may still report the 99211 if indeed a significant and separately identifiable service has to be done. And that will have to be supported with medical necessity. And I'll refer you back to the modifier 25 slide. There is an exception to this, however, and that has to do with Illinois Medicaid and 99211 with immunization administration. Illinois Medicaid does take exception to this rule, private payers do not. And the key takeaway here is that this is in writing. So you'll always have something to back it up. If you are doing something with a payer that's out of the ordinary or goes against CPT rules, make sure you have it in writing. So again, because the vaccine administration rates are very low with Illinois Medicaid, they do allow for the 99211 to be reported on the same day as vaccine administration, which is reported a little differently than we've been talking about, but that's a Medicaid VFC issue. But they will allow the minimal level office or other outpatient, depending on if the physician is required to be there, in addition for vaccine only encounters. I don't know how often this happens, and the reason I threw this slide in there because it came to my attention that every state varies on this issue. I recently had to look up, I believe, North Carolina and Texas ruling on this for other members of the academy about borrowing vaccines and what the rules were. So I just thought I'd throw this out there in case anyone had questions. They do have, every state does have their own specific rules on borrowing vaccines. So I just wanted to kind of lay this out there. It's very, very different than every other state. Most states do allow borrowing, and they have a lot of looser restrictions on this than Illinois seems to have. So I just thought I'd throw this slide in there, just kind of an FYI, because I was a little surprised by it. But you may all be aware of it. It was just new to me. So we're going to specifically talk right now about Illinois Medicaid and vaccines for children, or VFC. Because as I mentioned before, there are a lot of distinctions here. So again, always be very clear on who qualifies for VFC. Again, it's through 18 years of age. They have to at least meet one criteria. Not insured is related to a child who has no health coverage. And again, the American Indian or Alaska Native as defined by the Indian Healthcare Improvement Act. So just be very clear on who qualifies under that. This just talks a little bit about being, underinsured and who qualifies. We used to have a loose interpretation back when I was in practice because the rules were not as strict, but this is going back quite a few years. They're very clear now on what underinsured means. So again, be sure that the patient qualifies for VFC vaccines and does not need to be billed out to a separate payer. So again, in 2016, the rules did change for this. Children up to age 18 with Title 21 eligibility does not qualify. Children up to age 18 with state-funded eligibility do not qualify. And again, participants 19 years and older, regardless of title, do not qualify. So Illinois, the VFC has a website. You can search for practices who might be able to provide vaccines to Medicaid Title 21 CHIP recipients or those who are underinsured. There is a website I've listed here. This is kind of what the website looks like, and it does a nice job of finding people close to you if they need to be referred to an IDPH VFC provider. And back to the topic at hand is VFC billing. How does it differ? Well, we're not reporting administration codes. 90460, 61, 71 through 74 are not reported to Illinois Medicaid under VFC. Administration service is covered under the specific product code. The product code is reported in order to be paid for the administration. So again, this is very different than what we've been discussing this whole time, but these are the rules here in Illinois. There is a modifier out there, modifier SL, and this is reported with a vaccine when the vaccine is state supplied. And it appears that Illinois Medicaid does require this for the HPV vaccine if the provider is not enrolled as a VFC provider. This is typical for an OBGYN who may not participate but are giving an HPV vaccine to a VFC eligible patient. In this case, they will be paid for the cost of the vaccine. All right, now that we've kind of done all of that fun stuff and gone over the rules and regulations of all the coding, we're going to go through some coding options. This is specific to vaccine administration. It's kind of just a rundown of what we've already discussed. So we have a patient or a parent who is counseled by a physician or other qualified healthcare professional on one single component or multi-component vaccine. Patient is 20 years old. So what vaccine administration codes are we looking at? Well, we're looking at our 90471 or 90473. Because the patient is 19 years old, you cannot report the 90460. So it doesn't matter how many components these vaccines have. Again, we're stuck with our 90471 or 73 if it's a single one vaccine, depending on if it's intranasal or injectable, because we don't care about components here. Next, we have a patient or a parent who's not counseled on two multi-component vaccines. Both are injectable. Patient is 5 years old. Well, we have our 90471 for the first injection and 90472 for the second injection. Even though the patient meets the age requirement, since counseling is not done, we cannot report the 90460, 61 and get credit for the multiple components. Next patient is counseled by the nurse on two multiple component vaccines. Both are injectable. Patient is 5 years old. Again, 7-1 and 7-2. Even though the patient meets the age requirement and there is counseling, unfortunately in this case the vaccine counseling is done by a clinical staff, the nurse, and therefore does not meet the other qualified healthcare professional requirement laid out in CPT. All right, next one. We've got a patient or parent are counseled on two vaccines as part of a well child check. Because the patient is sick, the physician has them return in 2 weeks for shots only. When they return, the patient only sees a nurse. What codes are reported for the counseling? Unfortunately, we don't have any possible codes, so nothing can be coded for that. What is coded when the patient returns? 90471 through 74, depending on the types of vaccines and how many. Unfortunately, because the counseling does not take place on the same day as the administration, even though a physician did do the counseling, they do not get credit and cannot report the 90460, 61 when they return. All right. Patient or parent is counseled on a 3-component vaccine. Given that same day are 2 single component vaccines where no counseling is documented. The patient is 12 years old. In this case, we're reporting our 90460 for the vaccine that was counseled on, the 90461 in 2 units for the 2 additional components in that vaccine, and 90472 with 2 units for the 2 additional single component vaccines where there was no counseling. So again, we talked about intermixing the 2 code sets. You will use the 60 for the counseled and the 71 through 74 as appropriate for the non-counseled. But remember, you cannot report 90460 with 90471 or 90473. You have to use it with the additional vaccine administration code, so the 72 or 74. This is just an Illinois Medicaid vignette. So you have an established patient who presents for a 13-year-old well adolescent check. She has never received her HPV. The physician counsels the mom and the patient on the Gardasil vaccine and asks the nurse to administer. What is reported here? So again, you report the product code for vaccine administrations here in Illinois for Medicaid. So you're going to report your 99394 for the patient age appropriate preventive medicine service and your 90649. That's the product code for the Gardasil, which you will be paid for. So again, the same patient returns 6 weeks later for her second Gardasil, sees a nurse or a physician, really doesn't matter if it's just an injection only for a vaccine only encounter, nothing else is discussed. You may report your 99211 and then again your 90649. We don't report administration codes to Illinois Medicaid for VFC patients. Throughout here, there's some clinical vignettes you can refer to if you want to. This goes into some more detail on a 2-month-old checkup. A lot of this has to do with proper coding and proper modifier use. So when you're giving a maternal depression screen for a 2-month-old patient, and then you're also giving age-appropriate vaccines, your Penticell, your Hep, your pneumococcal, and rotavirus. So it's really important to take a look at some of these here, especially with modifier use. It's important to recognize that your 96161 code, which is your health assessment for the maternal depression screen, does have an edit with 90460, meaning it'll be denied without a proper modifier. So in this instance, you're going to do your 99391 with modifier 25, your 96161 with modifier 59. So keeping that in mind throughout here with all the vignettes, you're going to want to make sure that proper modifiers are used. So this is a 13-year-old that came in. Again, it's important to use our modifier 25 on our well check and our modifier 59 on the 96160 if you're giving them, let's say, a CRAFT or some other type of standardized risk assessment. Here's a 17-year-old. Again, very important to keep our modifiers. So this is going to be a well sick patient has an exacerbation of their asthma. So 99394 modifier 25, 99213 modifier 25, the 96160 59, 96160 59. So it's important because there is that edit on 90460. It will be denied. I was never going to get into the NDC. This is more for your reference, so you guys can take a look at this. Just be careful, know your payer rules on NDC. And these last few slides are resources. So links that you can have for your use. Again, the vaccine coding table, we have an FAQ on IA codes, implementation guidance for influenza, payer resources, as well as some of the resource links that came through in the slide presentation. And that is all for me. Thank you very much. Melissa, let me turn this back over to you.
Great. Thank you so much, Becky, for that presentation. Quickly, guys, if you have any questions, please remember you can put that on the right-hand corner. I believe we do have some questions. Give me a second. This looks like I can't see them. So our first question is, how do state get a report on vaccine compliance? Becky, if you want to unmute yourself and share.
Well, I apologize. I'm not as well versed. I have several colleagues at the academy who do more of the vaccine side, but typically the compliance, if the state's looking for it, that would have to go through your state registry. Unfortunately, it seems like there's not a good tie between payer data, what you're submitting, and what the state is looking for. I think the requirements are a little different, so I'm assuming that's going to go through your state vaccine registry. All
right, another question we have is what to do parents refuse vaccine at all. So any suggestions on that, Becky?
From a coding perspective, I'm not really sure how to answer that, but I know there's a lot of work being done on vaccine compliance, coaching within practices to convince parents. Probably one of the best things you can do is probably bring parents back for their own visit where there's no distractions. Maybe the patient's not with them, mom or dad can come in, sit down and talk to them. If the patient's not there, clearly you will not be doing a vaccine administration that day, so you do have preventive medicine counseling codes. At this time, we are working on an ICD-10-CM code for counseling encounter for vaccine and vaccine safety. So hopefully we'll get that next October. But your best bet is to probably have them come back alone, do a counseling visit with them, and hopefully you'll be able to convince them of the benefits.
I'm trying to see this last question. So it's for VFC administration at rural health clinic. I believe we can only bill for, and they put a code in there, a specific code. I'm not sure if that's a question or if you know what they're talking about.
So in general, rural health facilities do have, and federally healthcare, that federally qualified healthcare facilities do have their own rules on billing for many services that do differ from private payer and in regular practice settings and other facility type settings. So yes, I wouldn't be surprised if there is a variation there.
And then this is going to be our last question for now, since we're running a little bit out of time. If you have RN staff administrating vaccines to children 18 and under and are operating under a medical director, can you use the 90460, 90461, or do you have to use the 90471, 90742 only if the physician is not physically present?
So unless there's a distinction by your payer, yes, you will only get the 90471 through 74 because of that requirement or physician, another qualified healthcare professional counseling on that date of administration. And that goes for any practice that may have a physician who's there but not necessarily seeing the patients or is not present. But that is correct. You cannot use a 9046061 unless you have payer permission if the physician or other qualified healthcare professional is not doing the counseling that day.
Great. Well, thank you so much, Becky. If the remaining questions that are on here, I see them, and I will be sure to hand them over to Becky so she can answer that, and we can have that sent to you guys, along with a copy of the PowerPoint slides and a link to complete the evaluation and a link to the recording of the webinar in case there's anything else that you need to reference. That will be sent out by tomorrow. Please be sure to complete the evaluation by October 17th. After this date, the evaluation will be closed and you will no longer be allowed to fill out the evaluation or receive certificate for attendance or CME. So please be sure to complete it by the 17th. You will have your certificate sent out via email by October 31st. So please be out on the lookout for that. Sorry guys, I can't speak today. And without further ado, thank you again so much, Becky, for the excellent presentation, and to everyone for joining us on today's webinar. We hope that many of you will join us in the future. Have a nice day, everyone.